Many thanks to the International Continence Society Organizing Committee for giving us an opportunity to present our work on the outcomes of holmium laser for mesh exposure following synthetic mid-urethral slings and transvaginal mesh repair. I have no disclosures. Mesh complications are uncommon, but the consequences of mesh erosion into urethra and/or bladder can be devastating. Reconstructive surgery can be complicated and oftentimes challenging, requiring an open technique. We report on our outcomes with holmium laser mesh ablation in order to reduce such surgical morbidity. Our objective is to evaluate the outcomes using laser for exposed mesh. This study has been approved by our Institution Review Board. Patients from a mesh complication database presenting with mesh erosion from synthetic mid-urethral slings or prolapse repair for management at our hospital from 2013 to 2021 were included. All patients had minimum 6 months follow-up. All patients were evaluated based on their clinical symptoms, pelvic examination findings, diagnostic studies including cystoscopy and imaging where indicated, and validated questionnaires.
Using holmium settings of 1.2 joules and 10 Hz, the mesh fibers were melted until they retracted into the periurethral musculature. At these settings, this particular mesh exposure took 18 minutes to completely melt. Although early in our experience, we report 3 cases using the holmium laser for excision of eroded mesh in the lower urinary tract. Despite the feasibility of this procedure, we feel that it should be reserved for surgeons and institutions that are dealing with a high volume of mesh complications. This technique should be considered by reconstructive surgeons in their armamentarium along with open or vaginal using holmium set.
This is a short video presentation of our surgical technique using a hole-up sheath with a 0-degree lens and a 365 micron laser fiber introduced into the working channel with a uretary catheter. The laser settings used were 0.8 to 1 joules at a frequency of 8 Hz. We aimed for maximum mesh ablation until the mesh fibers are retracted into the urethral musculature or bladder musculature. As seen here, the mesh ablation before and after surgery shows significant mesh removal. Post-surgery outcomes measures were assessed subjectively with validated questionnaires and objectively with cystoscopy at 3 months, where resolution was defined as no significant residual mesh or reoperation required for persistent mesh. In regards to our outcomes, 23 cases were reviewed, 17 from mid-urethral slings and 6 from vaginal mesh. The mean follow-up was 30 months. The mean number of treatments required to achieve resolution was 2. Success was achieved in 21 patients, or 91% of our patient cohort. This flow diagram indicates that of the 23 patients treated, there were 1 failure in each group. Of those that were successful with holmium laser ablation, 11 patients required further reoperation for definitive management of their underlying urethral or bladder dysfunction, which included sling excision for outlet obstruction, fistula repair, anti-incontinence surgery for recurrent stress urinary incontinence, and cystodiathermy for recurrent UTIs. The functional outcomes are as stated in the slide. In conclusion, at a mean of 30 months follow-up, high mesh ablation success based on cystoscopy was possible. However, an average of 2 holmium laser treatments were required for mesh elimination. About half of our patients required further major surgery to correct underlying voiding and bladder dysfunction, but avoided major reconstructive surgery from the outset altogether. Patients who are considering these management options should subsequently be counseled accordingly in a tertiary referral center. Thank you.